The Schweitzer Institute's goals are to promote peace, humanitarian values, and health on a worldwide basis. And so it is a pleasure to have a speaker like Dr. Ho here, who has done so much on one of the most difficult scourges of our time, the pandemic of AIDS. And that's what he's going to be talking about, and I'm very pleased that he is here. To introduce him, I'd like to present Vince Petrucci, who will give his introduction. Thank you.
Good evening, everyone. My name is Vince Petrucci, and I'm the Director of the Office of Community Service. I have the honor of introducing tonight's speaker. But before doing so, I would like to acknowledge the hard work that made this event possible. Many thanks to facilities for the preparations tonight and their efforts in hanging the AIDS quilt. I would also like to thank the Schweitzer Institute, and particularly David Ives, for partnering with the office on this event. The Vice President of Student Affairs, Manny Guerrero, and the Division of Student Affairs for its continued support, and most importantly, my staff. Graduate Assistant Jen Waltz, Off-Campus Work Study Assistant Mike Mattis, Alternative Break Trip Assistant Tracy Diamond, Development Assistant Jordan Anderson, and Special Events Assistants Dylan Zikoski and Katie Burasa. You'll find them all at a table near the exit selling red ribbons and cupcakes to raise funds for a local nonprofit that we work with often, AIDS Project New Year. Special mention goes to Jen Waltz for her efforts in creating the posters chronicling the 30 years of the AIDS pandemic. Katie Burasa for her work in the spring of 2010 on the development of the HIV/AIDS awareness campaign, and Dylan Zikoski, who worked this semester on its development and implementation. Without their dedication to the office and the importance of this event, it would not have been possible. HIV has been with us for 30 years. From its emergence in 1981, it has spread to every continent and claimed the lives of millions. The scourge of HIV is one of the most pressing issues of our time, not only in the havoc it wreaks to the livelihoods and health of those infected, but in innumerable social costs. Even today, HIV is shrouded in discrimination and carries a stigma which suggests varying degrees of blame, shame, and fear. Those stigmas may be felt less today, but were devastating at the height of the emergence of the virus in the 80s and 90s. Schools refused entry to HIV-infected children. Medical personnel refused to treat HIV-infected people. Our government dedicated marginal funds to combating the virus. Those at risk of infection refused to be tested, and HIV-infected people hid their status for fear of losing their jobs, their loved ones, their homes, everything. That stigma, shame, and blame, and rampant discrimination was partially a result of who, at that time, the virus affected in disproportionate numbers. As the late actress Elizabeth Taylor discovered when she worked to develop a fundraiser after the virus had claimed the lives of thousands of Americans, no one was interested. The early struggle to respond to HIV was waged by the few who moved beyond labels and understood the human cost of the virus, people who rejected the malicious stigmas of shame, blame, and fear. One of those individuals is with us tonight, Dr. David Ho. He was named Time Magazine's Man of the Year in 1996 for developing the first effective treatment to combat the virus in HIV-positive patients and brought hope to millions. Due in large part to Dr. Ho's efforts, we no longer see as William W. Dodge IV the first person to receive the triple cocktail related. The younger generation doesn't know what an 80-pound, purple-spotted man looks like. I mean, the visuals of AIDS in the 80s and 90s and early 90s were quite startling. We don't have that anymore, end quote. And that is true for those that have the means to access the drug therapies that Dr. Ho developed. The focus of Dr. Ho's research has now moved from the treatment of AIDS to the development of the vaccine. He is currently Scientific Director and Chief Executive Officer of the Aaron Diamond AIDS Research Center in New York City, the world's largest private research center dedicated exclusively to fighting HIV. He also has a consortium of organizations working to address the crisis of HIV/AIDS in China and is the Aaron Diamond Professor at the Rockefeller University in New York. Dr. Ho has been the recipient of numerous honorary doctorates and has been recognized with the Ernst Young Prize in Medicine, the Mayor's Award for Excellence in Science and Technology, and the Scoot Award, amongst others. On January 8, 2001, Dr. Ho was presented with the Presidential Citizens Medal by President Clinton. It is the second highest civilian award in the United States, second only to the Presidential Medal of Freedom, and is granted to U.S. citizens who have performed exemplary deeds or services for his country, his or her country, or fellow citizens. I am honored and humbled to introduce an individual whose courage and dedication to do what is right has affected the lives of millions and continues to bring the world hope. Please join me in welcoming Dr. David Ho.
Thank you very much, Vince, for that wonderful introduction. Is the mic on? Okay. And thank you, David and Vince, for the invitation to visit Quinnipiac today. I had a number of very productive, pleasant discussion with the students, and I hope we could cap it off with a good discussion tonight. I'm going to tell you about the HIV/AIDS pandemic. I consider this to be the worst plague in human history. And because of my host tonight, I wish all throughout this effort we had someone like Albert Schweitzer to fight this epidemic with us. He's the consummate physician and humanitarian, and I'm sure his contribution to this epidemic would have been great if he had the chance. But there's a little connection which I'll come to in the middle of my presentation. As Vince said, AIDS turns 30 this year. It was in 1981 in the west side of Los Angeles where I had just finished training as an internist. So I finished my residency, and I was asked by my chief of medicine to stay for an extra year to serve as chief resident. And in that capacity, I had the luxury of seeing all the cases that had been admitted to the hospital the night before. And it was a little over 30 years ago that I saw this first patient, who was a young man who was very short of breath. And upon his chest x-ray examination, he had what we call diffuse pneumonia on both sides. And on his skin, there are lots of purple spots. And because of his severe shortness of breath, a bronchoscopy was done to diagnose what was going on. And it turned out to be a parasitic infection called pneumocystis. That was very bizarre because this type of infection only infected individuals whose immune system was down, usually due to chemotherapy or immunosuppressive therapy, but not in a previously healthy individuals. And these purple lesions on the surface, on the skin, were biopsy, and they came back to be a very unusual form of skin cancer called Kaposi sarcoma. We treated his pneumonia. It got better, discharged him from the hospital, and weeks later he died. This was a real mystery to all of us, and in retrospect, it's the first documented history of AIDS in this country. But then weeks later, there was a very similar case with, again, what we call pneumocystis pneumonia in another young man. And this time, this man also had another infection due to a different parasite called toxoplasma. And that infection was in the brain. We treated both of these infections. He got slightly better discharge and died weeks later. And in rapid succession, there was 5 such cases presenting to the western part of Los Angeles. And I just happened to be there, but these cases mystified me and my colleagues alike. We had no idea what was going on. But from that day on, I developed an interest and sort of followed my curiosity in wanting to know what was going on, and devoted the rest of my career to this problem, never realizing that it would turn into the global pandemic that it is today. Again, in retrospect, these initial cases formed the first report to the Centers for Disease Control. And the collection of patients and the term AIDS were officially defined by the end of 1981. All of these cases had a common feature. It turned out that all these young men were gay, and their CD4 T cells, a very important cell population, was depleted. And initially, this was thought to be a gay disease, but very quickly, the Centers for Disease Control identified additional groups, particularly among female sexual partners of bisexual men, people who use drugs by injection, blood transfusion recipients, and hemophiliac who receive blood products. And then lastly, children born to presumably infected mothers. So very quickly, it was defined that this is very quickly, this was defined as a some sort of infection that was passed by sex, by blood, and from mother to child. And we have since done many studies to understand the routes of transmission, and these are the only routes. This is not a disease that could be transmitted by mosquito bites or by casual contact. And it is important to keep the transmission routes in mind as you think about dealing with people who carry HIV. There's no need for irrational fear because this virus is not going to be casually transmitted from one person to another. I should tell you that very quickly, 2 years after the recognition of the syndrome, in 1983, the causative agent was visualized as shown on this micrograph. And it had the appearance, particularly on the left side here, of a retrovirus. And a year later, this virus was propagated and more definitively shown to be the cause of AIDS. And this is the virus we now call the human immunodeficiency virus, or HIV. And sadly, since 1981, this virus has spread throughout the world. There's no region of the world that's not affected. So every continent has the virus. But you should know that in the US, there are over 1 million cases. In South America, there are well over 1.5 million cases. But most of the cases, at least 2/3 of the cases, reside in sub-Saharan Africa. It's there where devastation is greatest. And also, the continent Asia, everyone I think has heard a lot about Thailand being severely affected, and that of course is true, but now China, India, and Southeast Asia, Indonesia are all having significant problems with this epidemic. And so today, 25 million people have already died of HIV infection, and another 35 million are living with an infection that is considered lethal if untreated. In the meantime, the epidemic rages on. We know that each year, in recent years, the new infection rate is about 2.5 million cases per year. That's approximately equal to 7,000 cases per day. And if I were to tell you that some 7,000 people are going to die of a single cause, you would treat that as a crisis. And in fact, it's disappointing to me that the AIDS epidemic for a long, long time now has been the silent tsunamis that's too often ignored by various national leaders. And as Vince pointed out, our own included. But I wanted to use the next few slides to paint a picture of the devastation that HIV causes in sub-Saharan Africa. It is the major cause of death in Africa, well above other infections like malaria, like TB, and so on. It's by far the major killer in Africa. And in many countries, the life expectancy has decreased. Instead of increasing like most other nations, life expectancy in the southern part of Africa has been shortened to near 40. That's about half of the life expectancy of people in this country. And all that because of one cause, HIV/AIDS. This is another slide from South Africa, actually the previous decade, basically showing the prevalence of HIV infection from the 1990s through 2001. And you could see among pregnant women seeking prenatal care, about a quarter of them carry HIV. And from these women, about 30 to 40% of their children would become infected due to mother-to-child transmission. And newborns infected typically die within 2 years of HIV infection. So many of those kids would be lost, but even those who escape infection are going to end up as AIDS orphans. And as David and I have been discussing today, there are now, in sub-Saharan Africa, 12 million kids who are orphaned by HIV/AIDS. So you could just imagine the societal impact that these numbers will have. And there are many documentaries that document the situation very nicely. I'm unable to describe it to you as well. The next is a number that will stick with many of the students in the audience, and that is the chance of a teenager in Botswana or South Africa becoming infected by HIV over his or her subsequent life is about 50% in Botswana and about 33% in South Africa. That's hard for us to imagine. And obviously, these countries need to do a lot to rectify this. But because the attention has shifted in this country, shifted to abroad whenever we talk about HIV/AIDS, I think it is my job to remind everybody here that the epidemic continues here. Each year we have 60, 70,000 cases in America. And that number has not declined over the years. And just from the size of these circles, you could see the areas that have been impacted by this epidemic. It's the Northeast corridor, the sort of the Chicago area, Florida, Texas, and California. But if you look at the map, which is actually on the upper right, which is New York City by the different boroughs, you see areas with the greatest red. And those areas have prevalences up to 4%. And if you know the New York City, you could see that it's South Bronx, Harlem, the West Side. The West Side is primarily the gay population, and regions of Brooklyn. And that's where the epidemic has really shifted into populations of color, particularly African Americans and to a lesser extent, Hispanics. So the demographics of this epidemic in the US has changed a lot. And in certain pockets, if you look at the gray bars on the left for certain pockets within US, and the right, the brownish colors denote different prevalences among African countries, with South Africa being the highest of the ones shown. You could see in New York City among gay men, it's still prevalence of 12 to 14%. But importantly, in places like Harlem, South Bronx, Baltimore, Newark, Washington, D.C., and I suspect New Haven, although that's not on the slide, that there are pockets, if you look in the African American population, the infection rate could go anywhere from 2% to 8%. It's quite high and it's scary, and it is a problem that we must continue to address and stay vigilant with. So what I do is primarily to study the virus. And this is a schematic diagram of HIV. It is a virus that is spherical. It has lipid envelope, so a fatty membrane, and there's a bullet-shaped core. And within this core contains the genetic information of the virus in the form of 2 strands of RNA. And embedded on the cell surface are proteins, and the core consists of core proteins and certain enzymes that the virus needs to carry out its life cycle. And all this is about a 100 nanometer in diameter, so it's about 10 to the minus 7 meters. So you can't even see it with a regular microscope. And the virus is actually from end to end 10,000 base pair long in terms of its genetic information. So it's tiny. It only has the genes depicted. It basically has 9 genes, and yet it manages to do so much harm to all of us with 25, 30,000 genes. It's so simple, yet it's so strategic in its attack on our immune system. Now, I won't bother you with all the technical details in terms of which gene does what. For the biology students, you could find that in textbooks or in reviews. But I do like to sort of just give you a taste of the scientific aspect of this virus, because you can't really appreciate this epidemic without knowing a little bit about our enemy. And I have a lot of respect for this foe. And our enemy, HIV, has a very straightforward life cycle. It's similar for all retroviruses. This is a virus. It infects a cell through specific contact with the receptor and a co-receptor. And then the viral membrane will fuse with the cell membrane. And you could see the inner contents of the virus gets injected into the cellular cytoplasm. And there, the RNA, the information contained in the viral RNA gets translated, well, I should say transcribed, into DNA. Hence the term reverse transcription. Normally in our system, the genetic flow goes from DNA, RNA to protein. But here there's a step that's rather unusual. It goes from RNA to DNA, hence the reverse transcription. Then that DNA temporarily is in the single strand form, but then it quickly is made double strand by our own enzymes. And then it migrates. It has a way of migrating through pores into the center of the cell, we call nucleus. And there, it gets inserted or integrated into the host DNA. So the virus, in essence, becomes a part of the infected person. And we have no way of specifically excising that virus out. That's why HIV is so difficult to cure. And from there, the rest of the flow is DNA to RNA to protein. And all the viral proteins have a way of spontaneously assembling near the cell surface, and progeny viruses will bud out through a process that we actually now understand rather well. And a single infected cell will bud out about 10,000 progenies. So that's the level of expansion that we could see with each cycle of HIV replication. Now, viruses by definition are intracellular parasites. They don't have enough genetic information to carry out all its function. It's reliant on our cells to do a lot of its business. So it's not surprising that it actually hijacks many of our gene products. Some examples listed here. It's not important what they are, but conceptually, the virus is hijacking our cellular machinery to do its business. So it's a parasite, so it has to do that. But what has been surprising in recent years of researching on this topic is that our cells actually have factors in red that tries to fight back and restrict HIV from doing its business. And this discovery is actually very important scientifically, not just for AIDS research, but for all of biology and human science. So we recognize that there's a protein. The name, again, is not important. That could recognize a viral core as it enters the cell. And this protein's sole function seems to be to cause the viral core to disintegrate. And the virus has a way to deal with that by changing its core so that it escapes from the human TRIM5 alpha. We also recognize in recent years that there's an enzyme inside the cell that will see DNA in single strand in the cytoplasm. Our DNA is typically in the chromosome within the nucleus. So anytime when you have a single strand DNA in this aberrant location, there's something wrong. It's usually viral DNA. And this enzyme's sole function today is to recognize that unusual form of DNA and try to mutate it so it would die. And there's another protein that's expressed on the cell surface whose sole function seems to grab onto viruses and not allow them to release. And therefore, the viruses cannot go on to spread infection. So HIV actually has come up with solutions. It devotes one gene product and another gene product to neutralize these factors. Of the 9 genes HIV has, it spends 2 to neutralize. That's how important these factors are. And we're just learning that there is, in fact, another layer of defense beyond antibodies, beyond T cells, but at the molecular level within cells that actually help us fight many, many infections. So you could ask why. HIV is a new epidemic. Why do these things exist? And I would simply tell you that there's a whole literature speculating on this, and it's probably through human, primate, and mammalian evolution that these things have developed to fight viruses that our ancestors fought. And in fact, you could see the evidence of devastation of these restriction factors on the retroviruses that are part of our genes now. And they have been devastated by this enzyme called IPAPAC3G. Now, that may be too much technical information, but I wanted to give you a flavor of what science could yield in terms of new knowledge and new broad concepts. Of course, understanding the life cycle leads to development of drugs. This reverse transcription step doesn't happen in our bodies, so it's unique to the virus and therefore becomes a good target for us to aim with drug development, because it's more likely to hit the virus specifically and have fewer side effects. And the first class of drugs developed were against reverse transcriptase inhibitors. And the next class, which I participated in developing, are these so-called protease inhibitors. Now, what is a protease? For those of you studying biology, it's an enzyme that cuts proteins. And a protease for HIV is there to cut the large components of the viral proteins into the smaller proper pieces that could assemble into a virus particle. Now, so it's basically a chemical scissor. And if you develop a small molecule that will gum up the scissor, the viruses that will be produced will all be non-infectious. And in fact, protease inhibitors do a great job at that. And more recently, we have developed inhibitors that would block the penetration step. And just in the last couple of years, there have been inhibitors that developed that are active against the integration step, so the virus cannot integrate into the host genome. So now we have 4 major classes of drugs, totaling about 30 different drugs from which we could use as our therapeutic arsenal. Last technical slide. We also understand a lot about the viral dynamics of HIV. What do I mean by that? And this is something that my group, contributed to immediately prior to the combination therapy. This is actually the foundation for using a cocktail of drugs. And you need to understand what HIV is doing in the body of an infected person. And I'm just going to summarize about 5 years of work on one slide, and with this information. So HIV undergoes this viral life cycle in the course of 1 day. So 1 generation, 1 day. For us, 1 generation is 20 plus years, typically. The infected cell doesn't have much of a longevity, the half-life. That is, half of the infected cell would die in 0.7 days. So the lifespan is 2 days or less of an infected cell. The virus that comes out into the circulation for us to measure only has a half-life of 30 minutes. That is, it's clear by the body after 30 minutes. But why do people maintain such a high virus load? It means that lots of viruses are being pumped out and lots are being cleared, so that it's a highly dynamic equilibrium or highly dynamic steady state. It's like your bathtub is always at the same level, but your drain is completely open and your faucet is completely open. Picture that for HIV infection. It's just churning away. And the numbers are absolutely astonishing. Billions or trillions of particles are pumped up by infected cells and they're cleared away. And billions of cells are constantly dying with such a short half-life, only to be replenished by new production of cells. So in fact, the body is struggling to keep up with producing these important T cells. And it's amazing that an infected person actually goes on quite normally for some 8 to 10 years. But this dynamic picture, what are the consequences? One is such huge numbers undergoing new replication every single day, and each time it goes through reverse transcription, it makes mistakes. This step is error-prone. It's not like our DNA synthesis, which has high fidelity, and we have an editing function. That is, if we make a mistake without copying our DNA, there's another enzyme that will edit that and fix it. HIV doesn't have that. So to me, I like to say this like akin to a child typing. There's a lot of typos, and the child doesn't edit. And therefore, the error rate is huge. So you take a huge error rate, a huge number, and a very short life cycle. The consequence is Darwinian evolution fast forward. And that it's at an enormous clip that, in fact, we could see HIV evolve inside the body of an infected person over a month. We don't have to wait thousands of years to witness evolution. We could see it in the viral population on a weekly basis if we want to. So that means to treat HIV infection, HIV is going to mutate so quickly that if you throw one drug at it at a time, it's going to find a solution to evade. What you're going to have to do is throw multiple drugs, so HIV has to fight them all simultaneously. And we could calculate mathematically how improbable that is. And that formed the foundation for combination therapy. And we actually provided the mathematical proof for that. The other implication is that HIV is actually churning away, even though the infected person may be well at the time, his CD4 T cell population is taking quite a hit. And so the concept of delaying therapy till the person is sick was always very foreign to me after we recognized what's going on. So the final recommendation is treat as aggressively and as early as possible. And that was basically the concept that we pushed forward in 1995, and a year later, 1996, it was clear to us that strategy was working in controlling the virus. And it is this type of control, the viral load in the red just drops, and we could in fact keep the virus down for years and years now. And it's not a cure, but it allows us to control HIV so that it destroys no further the immune system. And it is this type of therapy, if you just follow the blue line, that's the death due to HIV/AIDS in the US. Basically, 1996, 95, 96 was the turning point. And AIDS mortality has dropped 6-7-fold ever since. And it's made, obviously, a death sentence into a manageable disease. And of course, this development was celebrated in the developed countries like US and Europe. But very shortly thereafter, we hear the outcry from the developing world, particularly from Africa, what about us? And that imbalance, that social injustice, became very clear when you look at this graph. The improvement that I talked about is the graph on the bottom, the blue one. And that success is what we celebrated. But it's dwarfed by what was happening in Africa. That line went up from 96 to 2000 as if nothing happened, no development. And so this caused us, all of us working in the field, to think more deeply about how we then could deliver the therapies that are so helpful to American patients to Africa and other poor regions of the world. And not just the drugs, but the accompanying services. In addition, it also caused us to think more deeply about prevention. Basically, we recognize that you cannot treat your way out of this epidemic. You have to do prevention and halt or stop or slow the spread of this epidemic. And education is important. For the scientists, development of a vaccine is important. So essentially, these are the two aspects that I have devoted my career to for the past 10 years. And now I'm going to tell you about our failure to come up with a vaccine today and some of the approaches we're taking, embarking in a new direction. And then I'm going to tell you about the road that my group has taken in the field outside the US, trying to help a rural, a poor population in southwest China. To summarize it, we don't have a vaccine today, and we're not going to have one anytime soon. And you may ask why, and I would simply tell you, in my view, of course there are many scientific reasons, but the principal one that I like to highlight is represented on this slide and the next slide. So the virus particle is shown on the top left, and the protein on the surface, something called GP120 at the very top. If you take a top view and look down on that protein, this is the molecule you see. It's actually a symmetrical trimer, 3 units coming together to form a single spike. And that trimer is what allows HIV to find its target, It's also the target for our antibody responses. If our antibodies, part of our immune system, could recognize that trimer and neutralize the virus, we would have a vaccine. But there are entropic forces, glycosylation, variable loops. These are technical words. But I wanted to tell you that the functional part of this trimer is well protected by the virus. The virus has evolved a very clever strategy that is better represented on the next slide. So these are actual structures of the HIV coprotein. Looking at the top view or the side view. And these are the elements that are responsible for binding to the cell, allowing the virus to enter. And these are the targets for our antibodies. But in reality, this is not what our antibodies will see. That's what they will see. There's an extensive shield, consists of sugar, that the virus puts on the coprotein. And it basically protects the virus from our antibodies. And this has been why it's been so difficult to come up with a vaccine. And so to date, despite 20-some years of research, no one has been able to come up with a vaccine that is even partially protective. Many people have asked me over the years, where did this thing come from? And I think a lot of people know that it came from Africa. Exactly how, we don't know, and probably don't know the reason why we came to the conclusion that this thing came from Africa. If you take all the viral sequences that are available on HIV, and there are lots, I mean, too much for even a powerful computer. And put it on the slide, all the human HIV sequences would fall right here in these red branches under this M. But then if you go out now and do field work and sequence any virus that's related to HIV, particularly in this family of retroviruses, and you find that in black are all the sequences found in non-human primates. So up here, most of these are chimpanzee viruses. They're very close to human HIV. But here and down here are a bunch of African primates, non-human primates, that carry related viruses. And then up in this corner are viruses called SIV red-capped mangabey, because they come from red-capped mangabeys in Western Africa. And it turns out that these red-capped mangabeys could pass the virus to people as well. And this is what we call HIV-2. And you could see that there are many different transmissions. But this HIV-2 causes a milder form of AIDS. Now, everything in black actually causes no disease. That is, HIV in chimpanzee causes no disease. All these causes no disease. But in red, when the red-cap virus goes into human, it causes a mild form of AIDS. When it goes into another foreign species of monkeys, now these are called macaques. They are from Asia. Macaques from Asia get AIDS from the African virus. So the bottom line is that the natural host for the virus has no disease, but the new host for the virus develops disease. Why? We don't know yet. A lot of people working on that, but it's a very interesting observation. But let me come back to the point of where this thing came from. So it's clear that all these viruses only exist in Africa. You will not find them in the wild, in Asia, the Americas, Australia, or anywhere else. Even where there are primate species, there are no such viruses. So it's pretty clear that this entire group of viruses come from Africa. And of course, the immediate ancestor for HIV are these viruses. They are only found in chimpanzees. And in fact, only in one subspecies of chimpanzee, This is a part of Africa shown on the map here. And of course, this is West Africa, and this is Gabon and Cameroon and the Democratic Republic of Congo. And in red is the territory for one subspecies called Pantracholitis. Tracholitis is one type of chimp. And these chimps carry the ancestral virus. And it is pretty clear that HIV came from that population. Exactly how, we don't know. We don't know how the transmission occurred. We could speculate, since people in that region treat chimp meat as bush meat and actually sell that. So it's possible that part of the hunting and butchering caused the transmission, but that's speculation. The real answer is we don't know. And you could also ask whether this has occurred one time or multiple times. But the human infection suggests that all of it came from one origin, that there was some initial introduction and a big bang. But has it occurred before? Probably, but probably resulted in dead-end epidemics. But again, that's speculation. But we could ask, when did it occur? And this, we could give a decent answer, not a precise answer, but a decent answer. And it has to do with going back to this region, to DRC, which is formerly Zaire, Democratic Republic of Congo, and to the city of Kinshasa. In the old days, it was known as Leopoldville, I should say. And you could see, actually, this region, Gabon is where Albert Schweitzer's hospital is located, is located, and where he worked for 50 years. And to people of my generation, he's a hero and a role model, particularly if you're going into medicine. And he was awarded the Nobel Peace Prize the year I was born. So, what a coincidence. But anyhow, we actually have 2 samples from Kinshasa in that region that in later analysis were HIV positive. One is a serum sample and one is a biopsy sample. They've been sitting in freezers for decades. But because of a more systematic search, we've been able to identify these as HIV positive. My group worked on the serum sample. That was the first case ever documented. And we were able to sequence fragments of the virus. This sample basically, when we got it, the serum sample was dry, so it was degraded. And the biopsy sample was worked on by another group more recently. So the thinking is very simple. If HIV was introduced into the human population some time ago and then exploded, and if we look at this bush of explosion, you see this Big Bang effect. All the branches are basically different sequences from different populations. And it's spread from an initial introduction. So the reasoning is by 1959, 1960, when those 2 samples were taken, how far apart were these 2 sequences? And they were, in fact, pretty far apart already. This is our sequence from, this is our sequence from 1959. This is the 1960 sequence, also from Kinshasa. That they have flown apart already by the 1959-1960 period. This allows us to have some genetic yardstick to go back and measure. And without boring you with the math, it suggests that the initial introduction in the human population was in the early 1900s, around 1900 or all the way to 1920, or give or take 10 years. So it's now interesting to know that the virus, in fact, has spread probably very quiescently in Africa for a long time. And before it really got out of Africa, most likely in the mid-1970s, probably into Haiti, then into a US gay population, and then spread from there. it is important to know where these pandemics come from. And this is certainly true of flu and SARS and many other things. So in the remaining minutes, I'd like to just tell you about some of the work that we've been doing in what I consider to be a developing country, although most people don't consider China a developing country anymore. China, in fact, has 2 epidemics of AIDS. The first one is centered in the southwest, in the province of Yunnan and adjacent provinces. And you could see its close proximity to Myanmar, Laos, Vietnam, Thailand, and its close proximity to the Golden Triangle, where heroin is produced. And so this epidemic is propelled by injection drug use, primarily of heroin. And the Chinese side doesn't grow the poppy fields, but the Burmese side does. And actually, you could take a satellite photo of the poppy fields, and that would demarcate the Chinese-Burmese border. It's that powerful. I mean, the growth just comes up to the border and stops. And the border is porous, so the populations go back and forth. And it's cheaper to buy heroin than to buy cigarettes. And that's why there's so much injection drug use and so much HIV/AIDS. But in central China, centered on the province of Henan, the problem is actually man-made. And the provincial government at one time encouraged people to sell blood. And then because you have this business, there are always people who are there to take advantage and don't do selling blood, I would say there's not that much wrong if you do it right, but they did it wrong. And all this unsanitary ways of collecting blood caused probably close to 1 million people to be HIV infected. And so both of these epidemics occur among the poor, rural Chinese. And it's certainly not the modern China that most Americans see when they go to Beijing or Shanghai, depicted by these. And we all read every day that China's become a competitor and an economic juggernaut. But to me, China is still no competition because it has 800 million poor people that it must take care of. The 800 million live in rural areas. They live in settings like these. These are my own photographs. So they're very poor. The income typically is as low as $1 a day, and for the better off areas, it's $2 a day. And so the devastation amongst some of the villages that were very involved in blood selling was no different from what I witnessed in South Africa or in Tanzania and other regions of Africa. And in fact, it got to a point where in some of the villages, 9 out of 10 deaths, this is a funeral procession, 9 out of 10 deaths in the villages. Every time you see one, you guess it's AIDS, you've been correct 90% of the time. And so, so when we decided to go and help, our initial problems were so huge. It's sort of like the early 1980s that Vince talked about. We had to do something. But you can't do anything in China without the support of the central government. It's so top down. And so we knew that we had to change the political will of the Chinese leaders, and so that they could really commit to it. And in thinking about doing that, we actually had to elicit the help of a number of heavy hitters, such as former President Bill Clinton and on the bottom, 2 NBA stars, one former and one present, Magic Johnson, Yao Ming, one American, one Chinese, one infected, one uninfected. You could see the interplay for the two could actually help get attention and use that attention to educate the population. And I'm happy to say that by late 2003, the Chinese government began to take this seriously and set on the right course to manage this epidemic. And at that time, UN predicted China would have 10 million cases by 2010. 2010 has come and gone, and China still has about 1 million cases, 1 million, maybe 1.5 at most. So that titanic peril China had faced certainly never materialized, largely because the government was willing to do something about it. So our program, as Vince mentioned in the introduction, we set up an international consortium to help deal with this, and we were the first to do effective combination therapy there. We actually also help with orphans. There are, just like in Africa where there's HIV/AIDS, there are going to be AIDS orphans. And we saw this in central China and southwest China, and we had to go and raise a lot of money, private money, to help with their assistance. I won't bore you with all the details, but now I'd just like to tell you about one project that we're very proud of, and that we've been conducting over the last 5 years. And it has to do with a pregnant woman who's infected, passing the virus to the newborn. For me, traveling throughout the affected regions of China, it's really hard to see babies infected with HIV, knowing that they'll die in the ensuing month or a year or two. And yet, in the US, this type of transmission has virtually been eliminated. And I'll just show you one slide from New York City. In blue are the live cases, in red are the dead cases, but in all cases, you see the problem going away. Beginning to go away in the 1990s, and certainly largely gone by the mid-2000s. There's still sporadic cases, but those are the cases that the woman was never diagnosed. But in the US, if you diagnose, you could probably 99% of the time prevent infection. And so we wanted to do this, but to do this in the poorest part of China. And this is the Yunnan province, again, bordering Myanmar, Laos, and Vietnam to the south. And in yellow are the 13 counties where we set up sites to take on this prevention effort. And we realize our impact is going to be very small because we are a small organization and we only have so many people. But our purpose was always to do it and to demonstrate it and to leverage the government ultimately to do it this way. So we call it a demonstration project. In green are the sites that we have recently added. But the setting is either at home, so half of the deliveries occur at home. And here the people are making about $1.20 a day. And the average educational level is 4th grade. Or if they do go to the hospital, this is the hospital. This is the county hospital, one of the county hospital, shown on the left. This is a typical patient room, and this is the typical delivery room. I was horrified with the setting, and yet with this type of setting, we could still accomplish a lot. I won't tell you all the statistics about our women, but basically we enroll, in the last 5 years, 500 women into our program. And what do we do for them? The biggest part is actually screening all the women to find the positive cases. So we implemented province-wide screening, premarital screening, and anytime anybody shows up for prenatal care, they get screened. And to find the cases as early as possible and enroll them, and then administer therapy to treat the women so that the amount of virus is lowered by 100-fold or 1,000-fold, so that the chance of infection would be proportionally lower. And then when the newborn comes out, we administer a prophylactic dose, and then we replace breastfeeding with formula feeding because breast milk also has virus, particularly early breast milk. And then we provide counseling, support, education. And in the infant, Traditionally, you have to wait 18 months to find out whether your baby is positive or not. Because the maternal antibodies get transferred to the baby. So the baby, if you do the routine test, is always positive if the mother's positive. But the maternal antibodies gradually disappear. And then you could make a proper diagnosis if you're using antibodies. But that's a real nightmare for a woman to go through, or actually parents to go through, not knowing whether their child is infected or not. So we came up with early diagnostic methods using direct viral detection. And within 6 weeks of birth, we could tell them, your baby is fine. And that's obviously welcome news. And again, I'll show skip the technical slides. And basically, among the 500 women, we have 2 infections. And one of the 2 infections occurred in a woman who basically showed up at delivery, where we only had the chance to administer the prophylaxis to the baby. Didn't have a chance to treat the woman. But the other case got full therapy, still transmitted the virus. And these results are no different from what we could achieve in New York City. But the Chinese government is still using approaches that are suggested by WHO, largely designed for Africa, that leaves a transmission rate of 8 to 10%. To me, that's not acceptable. And without any intervention, the transmission rate would be 30 to 40%. So I'm actually just show you some of the happy faces. These are the happy outcomes. It's occurred in all but 2 cases. And these are the type of trips that my colleagues and I would take to visit our study sites. But the best thing is that the provincial government recognized the value and now has agreed with us to double our sites and to scale up our program. So instead of 500 women in 5 years, we're going to do 500 women in a year and really increase the capacity. And to integrate other prevention programs for hepatitis B, for syphilis, into the same. At the same time, while we have their attention, we actually teach them proper nutrition, particularly for the newborn. Because these areas are so poor, they have a lot of old concepts that are quite wrong about nutrition. And then I think the leverage effect is coming into play now. We basically shamed the Chinese government into doing the proper thing, to do it the right way rather than the cheap way. You cannot justify 10% transmission rate if we, as a private group, could do this with a transmission rate less than 1%. So they recently, about 2 months ago, announced that they will adopt this as their national program. So it's certainly very pleasing to us. And because I focus on that so much, I want to give credit to my colleagues who really carried out this work. On the bottom, Hao Yu Chen, who's a Chinese American, but speaks fluent Chinese, and he's based in that province. Katrine Myers, who's in public policy and public health, is a Harvard grad who speaks fluent Chinese and is my project manager. And she deserves enormous credit for the success of this project. And the 2 doctors on the top are our local collaborators. They actually lead a whole team of village doctors to execute. And to me, it could not be done without them. So I will like to conclude here. And let me thank David and Vince, and thank the university for the opportunity to visit and to understand Quinnipiac a bit more. And I thank the students for a lively discussion throughout the course of the day. And I hope we have a little bit tonight as well. Thank you very much.
You have a little bit of time for questions. You have a little bit of time for questions. There we go.
What is the biological magic of Magic Johnson, who has resisted that disease all through these years?
It's the same cocktail therapy that I've been talking about. We actually have been involved in his diagnosis and care since 1991, and he's the poster child for the success of antiretroviral therapy. I'm giving you public information, so I'm not sharing some confidential information. When he was diagnosed in 91, he was near the stage of AIDS. In fact, numerically speaking, he qualified as an AIDS patient. So he already suffered the consequences of HIV destruction, but he hadn't developed all the so-called opportunistic infections. But he was sort of managed with the older drugs for a couple of years, and then basically about a year ahead of the national program, because of our involvement, he got the combination therapy earlier than other folks. But then his results are representative of what we see in a large majority of treated patients today. So there's nothing magical about him. In fact, he is a representative of the patient population, and of course he's one of the most prominent faces of AIDS today.
Where do you see AIDS spreading the fastest? Is it in Africa or India? A few years ago, there was real fear in South Asia that India will become the epicenter of AIDS, and Bill Gates went there and donated $100 million to combat AIDS.
It is spreading in India. It's a serious problem. It's probably not as bad as was initially feared. The same story as China. They predicted 10 million for China. They predicted some enormous number for India, something like in excess of 20 million. I don't think those high projections would materialize. But that said, India faces a crisis. It's going to have millions of cases, probably in single digits. It's spreading mostly by heterosexual transmission, very much like Africa. And you could map out the towns that are affected by the truck routes, very much like Africa, and to some extent very much like parts of China now. And very much like the Deep South, you could track the truck routes and follow the towns in US the same way. But the numbers in Africa are still huge, particularly in southern Africa. So as a single country, South Africa has the most cases. India might be the second in terms of absolute number, but of course that denominator is much larger and the prevalence rate is much lower.
Has any patient or population been found to be naturally immune or being able to have some kind of enzyme and system to fight this virus and to be studied from?
Yes, there are certain genetic features that are somewhat protective. It may not surprise you that certain, what we call HLA genes, there are genes that help control our immune system. Some of those could make a difference. They're not completely immune, but people could live longer with HIV if they had HLA B57, HLA B27, so on. The technical aspects are not important, but there are a few such immune response genes that play a role in determining the outcome. But the gene with the most clear-cut difference is a gene called CCR5. I discussed this with the biology students this morning. CCR5 turns out to encode the co-receptor for HIV. So if you're CCR5 minus, that is, you don't have at least one copy of the gene, you're actually protected from HIV infection. But this gene, so-called defect, is actually only seen in Northern European populations and not seen at all in other populations. And that's the most clear-cut genetic determinant of infection and outcome related to HIV/AIDS.
A word about the sort of conflict between the patient right-based approach versus the public health approach to HIV, and the fact that there continues to be steady spread of the disease, steady influx of new cases, and what's your personal opinion as to what policy changes could come about that would reduce that?
Right. This has been hard, and HIV has been treated differently from other sexually transmitted diseases, most of which are reportable to the health authorities, and contact tracing is done to make sure that spread doesn't occur. But HIV has followed a different path in this country, largely because of historical reasons. As mentioned by Vince in the introduction, this was such a stigmatizing disease that if you wanted to report people and track partners, there was a whole community dead set against that because they were being discriminated, they were being marked as leopards, and so on. So that activism actually skewed the US CDC from doing the normal thing, which is to find cases, to find contacts, and to try to stop the spread. Over the years, the stigmatization, discrimination have decreased. They have not gone away, but decreased. And now I think the balance is shifting back toward the traditional approach. And in many other countries, that traditional approach has been taken. But it's almost sort of two wrongs trying to make a right. You know, I think what should have been done is to deal with the stigma and discrimination head on and say that's not proper. At the same time, the proper public measures be pursued. And so the government was forced into doing sort of several wrong things, hoping to get at the right position. But obviously, I believe that it's important that we stop the spread. But it's also important we protect the rights and dignity of people who are infected. And how you do that practically, it's easy for me to say that, but practically it's very hard to do. And I understand why we went through it, all the difficulties.
We have time for maybe one more question.
One hears occasionally conflicting reports about what the situation of AIDS is in Cuba, and I'm wondering if you could make any comments about that, please.
I would bet there's AIDS. There's a lot of AIDS, HIV in the Caribbean, and Haiti being the most severely affected in this part of the world. I would be shocked, but the formal statistics are always low. But then it's that way for, you know, if you go back to the 90s, it's that way for China too. And I actually don't know what the reality is, but I would be shocked if the government figures are correct.
Thank you, Dr. Ryan.